Welcome, everyone, to Health or Consequences. This is the monthly Massachusetts Health Policy podcast, sponsored by Commonwealth Beacon and Mass Inc. My name is John McDonough. I'm from the Harvard T.H. Chan School of Public Health. I'm your co-host, along with Paul Hattis from the Lown Institute. Today, we are discussing the consequences for Massachusetts of big cuts and changes to our Medicaid or Mass Health program, as well as to the Massachusetts Health Insurance Connector Authority and that kind of coverage through the Affordable Care Act and other cuts and bad things going on. Our guest is Victoria Pulos. Vicki is a senior health attorney at the Mass Law Reform Institute. She's been there since 2000. Before that, she worked at New Hampshire Legal Assistance. She's had many different careers in this field. She's a graduate of Harvard Law School, and we're thrilled to have her joining. Welcome, Vicki. Thanks for coming.
Thank you for asking me.
So, Vicki, can you give us just a little bit about your background? I know that in the health advocacy community, you are well known and a legend, and probably a lot of our listeners are less familiar. So can you just fill in some of the blanks that are most pertinent here?
Sure. So in terms of my work here in Massachusetts, I've been here since 2000, so that's a long time, 26 years, at the Massachusetts Law Reform Institute, which is a poverty law and policy center based in Boston. We also work as a state support center for legal aid programs throughout the state. So we focus on policy issues, but bringing kind of our legal chops to that, do some litigation, some lobbying, a lot of administrative advocacy, primarily at the state, but sometimes at the federal level. 3 of us in our health unit, and I am, we're all senior health law attorneys in our health unit. I am one of them. So I've been here for state health reform in 2006, for implementation of the Affordable Care Act, for the first Trump administration, efforts to repeal the Affordable Care Act, the pandemic and the pandemic response, how that affected Medicaid with the unwinding, and now this latest and perhaps the greatest challenge to the incredibly important Medicaid program and our state-based marketplace, and specifically the Connector Care program, which is sort of a unique Massachusetts variant of a marketplace plan.
So thanks for that, Vicki. That's terrific, and thanks for joining us again. So let's start with just putting out for our listeners the bigger picture, the big pieces that we're talking about in this. What's the big picture here?
Well, in terms of what we're facing looking forward, a lot is based on the state implementation of what has sometimes been called as the One Big Beautiful Bill Act, a federal mega bill that was enacted last July. We're going to be talking about it a fair amount and calling it OB3. It doesn't have an official name, but nobody wants to call it the One Big Beautiful Bill Act since it is the opposite of that. It was a mega bill. It did all kinds of things, but it really did a number on the Medicaid program in Massachusetts Mass Health, as you said. It both did and didn't do things to the Health Connector, make it for the marketplace coverage and premium tax credits. It did a lot of other things we're not talking about, including lowering taxes primarily for the wealthy and a huge infusion of funds to pay for the president's mass deportation movement and many other things as well. But just within the health space, it wreaked havoc. And many of the provisions are taking place over time. Some have taken effect now. Some will be taking effect from now through 2032. And its consequences will play out after that. In addition to that, we have there's what Congress did not do. They did not do it in the OB3. They let enhanced premium tax credits. This is the method that subsidizes affordable insurance through the marketplace in Massachusetts. That's Connector Care. And they let that expire at the end of December 2025, and that had consequences in terms of the affordability and the state's role in keeping insurance affordable there. Then we have just a hostile administration that has many, it seems like daily challenges that it's imposing demands on states. They're trying to portray the cuts as not really cuts because it was all fraud, waste, and abuse, and there's a whole campaign around that. There's trying to use Medicaid data for purposes of ICE enforcement. I mean, there's so many administrative things and regulatory actions on top of the big bill.
Vicki, this is Paul Hattis. Let me first add my words of welcome and thank you for sort of giving our audience an overview of OB3 and other aspects of congressional inaction and just the whole environment of this new administration. I want to focus on Medicaid for a moment. Can you tell our listeners what's happening starting next year around Medicaid and work requirements, both nationally and specific to Massachusetts?
Sure. And requiring work requirements in the Medicaid program was a feature of OB3. It will take effect January 1, 2027. It will affect not everyone on Medicaid, but the Medicaid expansion population. And that really refers back to the Affordable Care Act, which gave states, as interpreted by the Supreme Court, it gave states the option of whether to expand Medicaid for adults who had not previously been eligible for Medicaid, with the feds picking up 90% of the cost. And how it played out differed in different states depending on what their Medicaid program looked like before. But in Massachusetts, it's primarily people 19 to 64, not on Medicare, in a program that MassHealth created specifically for this group called Care Plus that does not offer all the same benefits as traditional Medicaid, which MassHealth calls MassHealth Standard. It's a big program, though. It picks up roughly 300,000 people. There are always fluctuations in MassHealth, but that's really the core population that's going to be targeted. And I say targeted deliberately. Remember, this is the administration that tried to repeal the Affordable Care Act, doesn't really think this is a population that deserves Medicaid coverage. They are people who, in Massachusetts, are low. Well, it's required under the statute. They are all low income. And what that means is, like for a single adult, their income would be lower than $1,835 per month. So that is not very much money. And it's primarily single adults, couples who are affected by work requirements. So the work requirements in OB3, first, the states have to identify the population subject to them, largely this in Massachusetts, this 360,000. You see both those figures, enrollment's always fluctuating, will be potentially subject to work requirements. There are a lot of exemptions in the statute, some pretty well defined, others really requiring federal guidance for states to know quite what they mean. If people are not exempt, then it means they have to spend 80 hours per month either working, participating in what's called community service, some kind of volunteering, participating in some kind of work training program, doing a combination of those things for 80 hours a month, or being enrolled in education on a half-time basis. There's also a provision that if your income is $580 per month, and if that's earned income in a state like Massachusetts, that would require that people who work much less than 80 hours, something like, I think it comes to 40 odd hours per month, would also be in compliance. One thing we're waiting for is for the federal government to tell us, is that just income of 580 or is it earned income? The statute says income. It doesn't say earned income. that's one of many things the state doesn't know. That'll make a huge difference in determining who's subject to these, who can easily comply with these work requirements just based on having
It
income.
seems that just showing that you are meeting the work requirements or exempt has its own paperwork burdens and administrative burdens. Can the state help people at all with that?
Absolutely. It can, it's required to under the statute, and the states vary in how enthusiastically they want to take advantage of those options. But Massachusetts is certainly wants to do what it can. And the chief way to avoid people losing coverage just because they can't handle the paperwork of reporting is if the state can identify them through data without asking them to do anything. Identify that they are working, identify that they're enrolled in school. There are a lot of exemptions that are tied to health status. Certainly people who are flat out determined disabled are exempt, but also people with various kinds of more serious or complex health conditions. The state, for the first time ever, and the federal statute really encourages this, is trying to identify people by claims data. That will be particularly important at renewal when people who are subject to this will have to report that I'm either in compliance or I'm exempt. The state can first look and see, well, we can see that they have some flexibility under the statute to flesh out these examples of these various health-related exemptions. That's another big area where we're waiting for federal guidance to be clear just how far the state can go.
Let me turn to another issue that we've heard something about. We know that people on Medicaid historically have had to reapply once a year, but I think certain categories of people at least will have to apply every 6 months, including in our state of Massachusetts starting next year. You want to tell us about that?
Yes, and that is again targeting the same population. It's really the Medicaid expansion adults who, instead of having to reapply or renew every 12 months, will have to do it every 6 months. And we know every time that happens, a lot of people drop off just because they can't handle the paperwork.
So, this is John. I have a question that crosses over Mass Health and the connector population. It seems that in the OB3 law and in many other moves that the Trump administration is particularly singling out immigrants to be removed from coverage. We're not talking about undocumented immigrants. We're talking about folks, for the most part, who are here with some legal guarantee of their status. Can you talk about what's going on in terms of immigrants in Mass Health and also on the connector side?
Sure. And OB3 is absolutely explicitly targeting immigrants, and they are all explicitly lawfully present immigrants. That is true in the health connector, where they're required to be lawfully present. It's to be eligible for the premium tax credits for the subsidy. It's true in Mass Health, where it's an even narrower category among adults. They have to be qualified, which in the past has covered some 8 different statuses: having a green card, being a refugee, being granted asylum. Well, OB3 is restricting that coverage. It's restricting it to just 3 categories of immigrants. Now, in the health connector, they had a very broad definition of lawfully present, people with temporary protected status. We have a lot of Haitians, Salvadorians, a lot of folks in Massachusetts with temporary protected status. They have work authorization. They've had that status for many years, some long enough to have paid into the system, qualify for Social Security and Medicare, for example. In Massachusetts, in Medicaid, it's a much narrower group, but they're limiting it to just 3 categories: lawful permanent residents, certain Cubans and Haitians with certain kind of status, and people from 3 islands: the Marshall Islands, Palau, and Micronesia. That's a very small population here in Massachusetts. So in That's going to have the biggest impact in the Health Connector because it had the broadest definition of lawfully present immigrants. Basically, if you had work authorization and did not have insurance through work and weren't on Medicare and were financially eligible, you could qualify for premium tax credits in connector care. So one group already lost coverage. Another thing in OB3 was eliminating coverage for immigrants under the poverty level who would have qualified for a Medicaid expansion, but for the fact that they were lawfully present but not qualified. That would include lawful permanent residents who are qualified, but in Medicaid, many have to have a 5-year waiting period before they can qualify. About 40% of the people who lost coverage, people under the poverty level who lost coverage January 2026 in connector care were these lawful permanent residents who just hadn't had that status for 5 years. So there were 37,000 people under the poverty level enrolled at the end of December, and January 1, when this provision of OB3 took effect, they lost that coverage. Some were able to transition to other kinds of coverage, but the vast majority, we think about 30,000 as far as we know, became uninsured and really just have emergency Medicaid and the health safety net. Now, the next thing that will happen is in Medicaid, and this is October of 2026, so it's coming up quickly now, when this same restriction, although now for adults applied to a much smaller group of qualified immigrants, will lose coverage. So this means adults who are refugees, who've been granted asylum, trafficking victims, domestic violence victims, people granted humanitarian parole, all these groups will no longer be eligible for federal Medicaid. We do have state-funded coverage. We've had that for a long time for both children and for elderly and disabled immigrants who are lawfully present but not eligible for Medicaid. So some of the elderly and disabled will be picked up, but the 19 to 64 year will likely lose coverage. And Mass Health is estimating this is a much smaller number than the Health Connector, some 2,500 people. And we're going to start hearing about this October because the federal Medicaid agency says we're not going to pay for them after October 1, except for emergency Medicaid.
So across the country, big changes to the Affordable Care Act coverage for people whose income level is just above what's required for Medicaid. And lots of people are already losing coverage. As an estimate, the ACA coverage will drop by at least 17% this year, perhaps more. That's out of KFF this past week. But in Massachusetts, it seems like it's less of a dire, desperate situation, and that the governor came out and said that there's money going in that will sustain the enhanced subsidies. Can you explain that for people?
Yes, I would love to do that because I think there's a lot of misunderstanding about it. It is very much a testament to Chapter 58. We're celebrating the 20th anniversary of Chapter 58. It set up the Health Connector as an exchange, or marketplace, often seen as a model for the ACA. It created a fund, which in the early days required massive appropriations in addition to the money already in the fund to provide subsidized coverage under state health reform, with some of that reimbursed through the Massachusetts Medicaid 1115 waiver, but less than 50%. When the ACA came along, now the federal government was offering entirely federally funded advance premium or refundable advance premium tax credits to lower the cost of private insurance purchased through the marketplace. So the connector retooled to continue the same kind of coverage under this different structure. But they soon recognized that they'd been defining affordability since 2006. We know what affordability means in Massachusetts. And even though the Affordable Care Act was great, it made coverage more affordable than it had been, it really was not affordable in Massachusetts. So we retained the trust fund. it still required some appropriations, but a lot less, to supplement the federal premium tax credits and make it affordable in Massachusetts. Now, when in 2020, the federal government enhanced premium tax credits. So now they were, in some cases, paying a larger share than even the combined federal and state share in connector care before. And they totally lifted the upper income limit. Premium tax credits did not apply to people whose income was over 4 times the poverty level. So during those 5 years, the connector care did not have to supplement the federal premium tax credits very much. And in some cases, people were getting insurance at a lower cost than they would have under the old days. That was certainly true for the let me leave it at that. And in part because it needed so many fewer dollars at the state level during those 5 years, the trust fund built up a balance, and they were able to expand connector care. At one point, it had always been 0 to 3 times the poverty level, and 3 times the poverty level, just to put that into context, that would be like this year in the health connector, that would be like a little under $47,000 a year. So they raised that first to 500% of poverty. And so when the enhanced premium tax credit expired, because it was initially a temporary COVID thing, it was renewed from year to year, was wildly popular in other states, and this included even the red states that had not expanded Medicaid. All states were participating in the marketplace. If they didn't set up their own, it was the federal government. They had way more enrollment, but when the enhanced subsidies expired at the end of December, many people in other states suffered huge premium shock. In Massachusetts, the connector continued business as usual. They determined what was affordable. They drew on the trust fund. They had enough in the trust fund. They didn't need an additional appropriation. They said it amounted to $250 million required to continue providing supplementing the now lower federal share of premium tax credits.
But is that just for 1 year, Vicki?
Yes.
So it will run dry in a year unless something else happens.
No, the trust fund has it's never run dry since 2014. The trust fund has independent sources of revenue. There's $1 on the cigarette tax. There's an employer assessment that used to support a different kind of health insurance program for people collecting unemployment insurance. There are the individual mandate penalties, and there have been over the years appropriations of different amounts when required. So there's no reason to think it will run dry, and it still has a surplus.
Vicki, since we're starting to talk about money a little bit, let me move it to a macro question about money, because we all know that OB3 and other developments are leading to significant amounts of revenue dollar loss to states, including Massachusetts, around Medicaid and other things. Tell us what the impact dollar-wise is projected to be for our state.
Okay, so OB3 made a lot of pretty technical changes in Medicaid financing and the ways that states could raise money and pay providers without drawing a lot of general fund dollars. So I'm not going to attempt to explain that in any detail, but what the state has estimated is that when all the different features of the OB3 are in place, and they won't all be in place until 2032, although most will be in place by 2029, and counting losses both at the health connector of premium tax credits that are not being paid to insurance companies in Massachusetts, as well as losses of federal Medicaid, that it will be $3.5 billion a year of lost federal revenue, federal funds coming into Massachusetts as a result of OB3. And there's a corresponding number they've been saying for quite a while from the state that this could mean 300,000 people losing coverage between the work requirements, the complexity of that, the redeterminations, and other factors, as well as the immigrants who just explicitly, the rules have changed. They've lost their coverage. That the connector has said that's going to be 65,000 lawful immigrants. And again, Mass Health has said a much smaller number of the immigrants. But in total, it could be 300,000. That Kaiser report you mentioned, well, in other reports too, there was a recent RAND report. They've been estimating lately coverage loss in terms of states that take low mitigation, medium mitigation, or high mitigation approaches. This goes back to your earlier question, Paul, about what can the state do to prevent coverage loss. So there's a range there, but it seems inevitable there's going to be eligible people losing coverage because of the complexity of these new work requirements, which, by the way, it is very well established because they were tried out in the first Trump administration. They don't work.
So, Vicki, you've really detailed in so many ways, enrollment-wise and even dollar-wise, the challenges that exist now in Massachusetts, even worse going forward. How do you view overall or grade even state government's response to date in dealing with all these issues?
Well, for the work requirements, the state is definitely talking the talk. They are saying they want to minimize coverage. The legislature has appropriated funds for Healthcare for All to do an outreach and communication campaign similar to what they undertook during the unwinding. There's a lot that's promising there. We don't know yet what it's going to look like. Partly it will depend on what guidance comes out from the feds. Partly it will depend on execution. The state has not always been good in its IT system changes, its training, its customer service. We don't know. So it looks like they're saying the right things on trying to minimize coverage losses in Medicaid. The connector authority, the connector board, the connector staff, they're fabulous, but they have not come up with a solution. They have not stepped up, nor has the governor, the state, the legislature, on what we do about lawful immigrants who have always been covered since health reform, with a few breaks here and there in 2006, to provide some kind of bridge for them of coverage until we have changes in Washington. So that would not be a good grade. That would not be a passing grade in my book as yet, but there's still time.
So final question, Vicki, can you give us a sense of what you see ahead, what's coming up in the short term, the medium term? What do we know is going to happen? And also, I think a number of people are thinking, well, Democrats are maybe going to take back the House and the Senate in November, and can't they reverse all of this? So could you put some context for people in terms of what to expect coming up?
Okay, so, I mean, in the very short term from OB3, we have all these deadlines where various provisions will take effect, with a lot happening January 2027. A lot of the terms in OB3 were not defined, and states are waiting for guidance. The statute required the federal Medicaid agency to come out with interim final regulations by June 1st, and a lot of things depend on what will be in those regulations. We understand they have been filed with OMB on April 1. So there's what the professionals who work for the Medicaid agency, the nonpartisan professionals, put together based on the statute. And then there's what happens at OMB, headed up by Russell Vought, who's the author of Project 2025, and what the White House may do with some of the provisions of OB3 that. So we don't know. A lot depends on that. In terms of the election, I think that can make a huge difference in some ways. In others, it's really challenging to see what they can do. We'll still have a president who's likely to veto any attempt to flat out repeal what he has dubbed the One Big Beautiful Bill Act, although now they're trying to rebrand that. There should still be some areas where it's possible to find a compromise. For example, the enhanced premium tax credit. At one point, it seemed like maybe that could continue, and there may be other aspects of this, especially as things roll out and there's more of a pushback. We didn't even mention Medicare is going to apply these same restrictions to immigrants. They're going to be cutting people off January 2027. These are immigrants who have worked, paid into the system, earned their Social Security. They're not losing their Social Security. Earn their Medicare. They're taking it away. We don't have very good numbers on who those are, but that one really shocks me. So maybe some of these things there would be enough sentiment, especially if the elections give the Democrats an advantage and the Republicans a backbone.
Well, so Vicki, a lot to think about, a lot to be concerned about, and we're very glad you're on the front lines looking out for people. Thanks for your great work, and please keep it up. Thanks for sharing all your incredible intelligence, and sorry we didn't have 3 hours for this discussion today because it's so rich and there's so much there. So thanks for doing it.
And thank you.
Thanks to my co-host, Paul Hattis. And this is John McDonough. We'll be back next month with another edition of Health or Consequences. Thanks very much, everybody.